We cannot call fertility service as non-essential. It's definitely time sensitive.
You have been working with Dr. Vermesh in the Valley for how many years now?
I would say I'm in LA about 6 years, but before that, I am in this field about 13 years.
Yes. I was going to say, it feels like so much longer.
I know.
But when you joined his practice, it was such a beautiful complement to his masculine energy for you to bring the feminine, the emotional piece, the yin to the yang, as we would say in Chinese medicine.
I really appreciate your comment, and I really do think that we make a great team together. We complement each other, and it has been a pleasure working in that office and with the whole team.
Mm-hmm. Yes. Yeah, I mean, off record, that practice is my favorite one to work with. It's not necessarily the one that I work with the most, but I feel the most of an alignment over there. And it was funny because when we met, we were talking and we realized that we have the same birthday.
Yes, I remember that day. And it was very interesting because when I started working in that practice, I get to basically know the whole team. And in one of those days, I met you coming with my CV and saying, Dr. Tolou, we have the same birthday. Yeah. I was like, oh, that's fascinating. That's interesting. And we share a lot of common, I think, characteristic in general and how we approach the patients. And the fact that we, support the patients outside of what the practice needs. It has been circumstances that I get a call from Danica and wants to talk about this problem, or, what do you think of changing this or that, or the common patients that we have. And I really appreciate that. The fact that we see the patients, they can trust us, that it's not just about the fertility challenges, it's as a whole patient in terms of how we can approach their psychological and emotional part of these challenges. That's very important. And I really appreciate you, Danica.
Oh, thank you for saying that. It's true. I think we're in a medicine that could so easily slip into the patient's feeling like an ID, a patient ID, or a set of lab values, or old ovaries, or poor responder diagnosis labeling. And at the end of the day, they are humans, and they are women going after their biggest goal ever. Second to finding the right partner is this creating their family. Yes. And I think as a field of medicine, at least here in Los Angeles, we have come so far to blend the two bits of medicine together, and the patients are the ones benefiting as a result. And they now understand that it's okay to be emotionally attached to the outcome, and to be upset is normal and natural.
That's
when
correct.
It doesn't work out.
I do believe that infertility is really personal. Mm-hmm. And there are many factors that influences that how they perceive the diagnosis, how they address, and how they cope with the challenges. And as part of those factors, I think their background, their cultures plays a significant role. Yeah. And to understand that, okay, what are the thought process and how we can basically propose protocols that are more inclusive and supportive of their differences. It makes a big difference in terms of making basically helping the patient to get through this roller coasters of events.
Mm-hmm. To a successful outcome.
Exactly.
Yeah. Well, I'm so glad that you brought that up about the different ethnicities, as you know that when I was working on my doctorate, I had those 10 case studies.
I remember
and they
that.
were all poor responders. And that's where I saw that women of an Indian descent, meaning from India, Hindu, or Asian, Chinese, and Middle Eastern, they tend to have a smaller reserve. And I kind of knew that from my acupuncture practice, but when the data came through and those were the patients that signed up to be in that study, there it was. It was really fascinating. So I want to talk about that, but I really want to start the interview by letting the listeners know who you are, where you came from, and how you came into fertility.
Sure. So, Danica, I'm originally from Iran, and I was born and did my medical education there. And while I was planning to prepare for the next step in life and basically to find the best match for my career choice, I came across reproductive medicine. And at the time, this field was very different, and it was a novel field and very high tech. And the fact that now with just having one egg and one sperm, we can have a baby, it was like a science fiction, right? It was very new, and it was fascinating to learn that, how assisted reproductive medicine can basically give hope to countless individuals that now they can fulfill the dream of the parenthood. Now, as part of that, also more I delve in this field, I realize that it's just not about human biology. There is about the psychological, emotional factors that play a significant role. And at the same time, it was rapidly evolving and changing. And not only it did help patients that they have difficulty to conceive, now we can address some genetic disorders that we can, by doing this type of treatment, to prevent it to get to the next generation, which is a big deal.
Yeah, preventing those
so at that point, I decided, okay, this is what I want to do. And this is not only anymore a career choice. I felt like it is a calling because I could feel myself in that situations, in that positions. I knew people around me that they were going through these challenges. So I moved to United States. I started my training in University of Miami, did my residency there, which was a great experience. Again, this was a multicultural city. I get to work with different type of patients, individuals that the definition of infertility was different for some of them, and how they would approach, sometimes using home remedies. Sometimes they were, mindfulness that they learn from their home natives, not really, seeking professional help. So that gives me an idea. It gave me an idea of, okay, everybody is different, it's the same entity, but how we can proceed and how we can help them should be personalized. It should be individualized. Then I moved to University of California, San Diego to continue my fellowship. So I did my training there. And again, this was a different environment. Now we are in California. And the way many patients, they approach infertility was trying to work more with integrative medicine, holistic medicine. And then from San Diego, I moved to Los Angeles. And again, different patient population. And I started practicing in Valley, Center for Fertility and Gynecology, and since then I'm still there and seeing a variety of patients.
The San Fernando Valley has that nice melting pot of the different ethnicities too, and the holistic bend, and passing on some of the ancestral remedies and stuff. So maybe that was all leading you there.
Yes,
right?
I'm happy to be here. And
is there a special focus within fertility that you see repeatedly coming to you, or something that you really get excited about when it's presented?
I would say I see a variety of patients from different age group. I work with oncofertility patients. Those are patients that they are very young age, they're diagnosed with cancer or some medical issues that immediately they have to start the treatment, and they can it can jeopardize their future fertility. So there is a time limit and how fast and how quick we can get things done. Also, I see patients with male factors. Male factors with sperm issues, sometimes low sperm, that we have to interfere and help them to get started treatment. Patients that are having ovulatory problems. I'm very active in operating room. I still do fertility operations. So sometimes they just need to remove a fibroid or a polyp, and I'm very active taking them to the operating room myself. Don't refer them out. But a wide range of patients that I work with. Yeah.
I definitely want to talk to you about endometriosis, because wasn't that something that you were doing at UC San Diego?
That was my focus on inflammation, and also how the pre-existing inflammation can exacerbate the implants. And I had a very interesting research that we published, and my thesis was, okay, if there is pre-existing inflammation for whatever reason, and we have implants,
endometriotic
implants, does that pre-existing inflammation exacerbate the implantations of those implants and basically size of those? And definitely it did.
So you're saying like a connection between pre-existing inflammation plus endometriosis adhesions.
The severity of the symptoms, and yes.
Mm-hmm. That's fascinating. So then when COVID happened, that inflammatory virus, I saw a correlation in my endometriosis patients. I'm sure you must have been zeroing in on it, right?
Yes, those days where the global pandemic definitely was eye-opener in many sense. I think one of them was at the time we did not have enough of testing. At the beginning, we didn't have enough of testing. So we would see, okay, this patient used to have a very good sperm. Now, all of a sudden, he has none. Mm-hmm. Or this patient used to have a very good response to the stimulation protocols. Now, that's not there anymore. Mm-hmm. Or when we were planning to transfer and preparing the endometrial lining, the lining wouldn't get to the point that we were hoping to plan for transfer. Mm-hmm. And the question was, is this related to the actual, this patient had COVID virus, and that's why, we are seeing all these changes in their reproductive health? Or no, it's just the effect of the circumstances, the intense stress level that patients they were going through, or diet changes, changes in their exercise habit, mm-hmm. isolation. Mm-hmm. And luckily, after we had enough data in 2022, 23, the studies came out that it was just not our center, our patient, it was nationwide. Mm-hmm. And I think we talked in between at some point. Mm-hmm. We had this phone conversation, me and you together. I don't know if you recall mm-hmm. that.
Oh yeah, I'm going to mention it in the interview.
Yes.
Yeah, but it is really interesting that your background was in inflammation, and I think it would be valuable for the listeners to have an understanding of how we become so inflamed in the first place. Could you speak on that? Like, I would think it's like the food is probably the most obvious, that we're eating food that's so much sugar, but then the emotional piece, particularly in fertility, where they're trying to do something and it's not working. But is there a genetic component or some other piece from science that makes a person particularly prone, or something in their immune system that makes them more prone to having inflammation markers?
I think there have been very good studies regarding inflammation and is this something genetic? We know, for example, in endometriosis patients, they have the genetic predisposition. There are females that their mother had endometriosis, so there is a genetic component in some cases. Also, at the same time, we know we can modify it. So when we change certain things in patient diet, their habits in terms of their social habits, their stress level, it does improve their symptoms. So I would think it's more multifactorial, and in general, some of the time it's reversible, and certain individuals, we see that when we change their, for example, their sleep pattern, simply as that, their symptoms are different. So we know the stress increases the cortisol, and that's for sure, and that's one of the area you're working on, and how that stress can affect the symptoms and inflammation is proven that it does affect it. But again, I think it really depends on different person and how that stress level it jeopardizes their biology. Yeah.
Right. Somebody who is getting a lot of good sleep might have a genetic disposition to having endometriosis, but that restorative sleep and a good diet could help them to not be so easily inflamed, whereby somebody who has a perfect diet but a stressful mindset and a stressful attitude towards life, I like to describe it to my patients as like an internal battle where they're battling with themselves and creating that heat or creating an autoimmune condition, right? The inner heat where it's like they're simmering inside with how they're feeling about things and not feeling like they can do anything about it.
That's 100%. And I think one thing that we learned from the global pandemic was the effect of, the intense stress on our biology. In general, we had patients that they had changes in their menstrual pattern and the length of cycle. And when we look at their ovarian reserve, sometimes we were seeing lower number of follicles, but over time, when the stress level was lower, we could see more. And again, I think there would be more study coming out to address these circumstances.
That conversation between you and I that you mentioned, that phone call, that was April 2021. And I was getting ready to speak at a integrative fertility symposium on the effect of COVID stress. So it was really before any vaccines had been rolled out. It was, they were rolled out, but there wasn't any data, and that wasn't what I was calling you about. You were one of a dozen physicians that I wanted to informally survey to find out, what are you seeing in your patients, just kind of off the record. Was it fewer eggs recruiting? Was it uterine lining not proliferating? Was it a higher number of IVF cycles being canceled because the eggs weren't responding to the medicine? Or was it the very sad loss of normal embryos when we knew they had been tested for euploid status? And you being one of the participants in that conversation, you wouldn't know, but what I was knowing was that across the board, everybody was saying, yes, sometimes it's the lining, sometimes we're seeing reduced egg or sperm count, but this really sad thing is that we're seeing so many miscarriages. But the patients, they didn't have any idea that this was going on because they were isolating. So if fertility is sort of isolating to begin with, they definitely weren't having their conversations with their community at this point. They were just even more inflamed and scared because the centers had been mandated to close down by ASRM. So they didn't realize that they were having these miscarriages and that a lot of other women were too.
going through the same.
So what I loved in that conversation with you was that you were willing to say high amounts of cortisol will lower the estrogen. And without the estrogen support, the lining cannot thicken. The eggs will not have as much of a strong response to stimulation protocols to make a good crop of eggs. And I really appreciated you validating that. And without that estrogen, then those linings were compromised.
As you remember, it was a lot of gray zone at the time. And even to define if fertility services was essential or non-essential, we had to fight. And nobody knew, okay, can we provide this type of services at this point? Because it's time sensitive. Not everybody has a whole year to wait and start their treatment protocol. And as you mentioned, we had patients that they had preparation, they transferred the normal embryo, now they have miscarriages, now they're ready to start the next step. And I think it's to be proactive about all of these issues at the time. It was very helpful for us and also for our patients. We could help them, and at some point we collectively, all the physicians that we could gather a team. We argue with ASRM that okay, this is really we cannot call fertility service as non-essential. It's definitely time sensitive. We have to help the patient. So we started the protocols again. We started to see the patient. Of course, one thing that COVID helped enormously was to basically adopt the telemedicine and telehealth. So we could see the patient, but not physically being in the office, but, we could talk to them, plan what's the next step, and basically help them to move through this, that timeline. And we could kind of resume our treatments. And it was an interesting time, and I'm glad it's past that. Yes.
Yeah, let's leave that in the past. But what we learned from there is the role of inflammation, and something that I don't think was expected, but your work studying endometriosis, this probably wasn't so surprising for you. When those protocols, for example, like luteal phase estrogen priming, used to be such a good protocol for having a crop of eggs come through for poor responders, and we would see more eggs. But post-COVID, especially in the women with endometriosis, when they used, and sometimes in some cases now, when they use some estrogen, it suppresses too much.
Yes, it really depends again, it should be personalized and individualized. I used to use that same protocol, estrogen priming mid-cycle for patients with diminished ovarian reserve, and also including Clomid when we are doing the stimulation. And I saw a diverse response to the same protocol. And then some patients, they really don't do well with that estrogen priming.
In the past, we could use that luteal phase estrogen priming protocol, and it would soothe the ovaries. It was a calming hormone. But then suddenly, with inflammation, whether it's from stress, diet, COVID antibodies, COVID infection, COVID vaccine antibodies, somehow that inflammation does not feel calmed by adding estrogen. It hypersuppresses.
I used to use that protocol for many patients in the past. And the thought process behind it, the mechanism of action was when we add the estrogen pre-stimulation, we should get more follicles, especially in diminished ovarian reserve patients. But what I would say, and I think there would be it would be interesting to do some research and more studies and add patients together to see why there is a difference from a couple of years ago before COVID and now. When we add that estrogen priming, some patients, they really don't do well with it, and they simply if we start with their own period without any priming, we have better outcome. Is that because of the, again, changes that we went through in the last couple of years because of, COVID and stress, change of diet, change of weight? I have no answer for that yet. But yes, we have noticed that change, and we rarely use that estrogen priming anymore.
So here in the office, seeing various different doctors' patients. I see patients from different clinics.
Right.
And that gives me an opportunity to kind of have these mini trials that I'm doing, whereby I started as an endometriosis patient myself to see the correlation of endometriosis and stickier blood. Their menstrual fluid might be more stringy with mucus strands, more clumps and clots. So in Chinese medicine, we view that as blood stasis. But particularly in the era of COVID, what we learned was that the idea of microclotting, where the little capillaries that are on the ovaries or that are filling the uterine lining, they are becoming filled with little clots that's blocking the flow of oxygen and the flow of blood. So what I did is I started giving my patients a combination of fish oil, vitamin K2 that helps to move plaques out of the blood vessels, and an enzyme called serrapeptase that is to reduce inflammation. And as a result, I saw a shift where the egg counts went up and the miscarriages went down. And I think it was like a three-pronged kind of holistic approach to hit those microclots and start dissolving them and free up the flow of blood. But there's nothing matching that in Western medicine. So it's kind of like I just kind of secretly hope, or I say to my patients, if they tell me he wants to do birth control or she wants to use estrogen priming, then I say, well, maybe you can ask to have like a non-medicated cycle and then just use the stimulation protocol. So you're validating that that is what's happening right now, is this medicine has to keep changing all the time to meet the needs of the patients at the time.
Yeah, so we have to adjust the protocols. And I'm glad you mentioned that, because one thing that we add when we start the stimulation or at the time of the transfer is a medicine, it's not a supplement. We add aspirin, right? So that has the same thought. We have the same thought process that we want to decrease the clotting. We want to have a better blood supply to the uterine cavity, to the lining, to better blood supply to the ovaries. And what you're adding as a supplement, it does the same effect, So that's where I think the integrative and multidisciplinary approach is important to, again, understand patients, what's the diet, what's their habit, what are the things that we can improve by adding healthy supplements. And here we are, we're on the same page.
And here we see now fewer miscarriages happening and the egg reserve is starting to come back. And I don't know, is the sperm count starting to go back up?
We don't use aspirin for men, but what we can see, again, during the COVID time, we had significant issues with the sperm production. Not necessarily the patients who had COVID or were significantly ill. They were patients that they had no symptoms, and all of a sudden there's no sperm. And yes, I had a fever maybe, or I didn't feel that great, and sure enough, probably they had the virus. Again, not everybody was also checking. Now we are out of that, and we see improvement in the sperm, and we have more modalities to check to see if they have any sort of illness. But I think severe illness, being febrile, definitely does affect the sperm production. Plus, a lot of environmental factors that I think we should talk about and we should consider when we evaluate couples. we see low sperm. Why we are seeing low sperm? This patient has no medical problem, doesn't have high blood pressure, doesn't have cholesterol, is not diabetic. But then, yes, when we talk, oh, I work in oil field, I'm exposed to pesticides, I'm a driver sitting 7-8 hours driving to my work. So here we are, we have the answer. So there are a lot of occupational factors, environmental factors that it is happening.
And those are probably, I think that women are hearing environmental factors and thinking, oh, but I already switched my Tupperware to be glass dishes, or I'm not using those products,
the BPA.
but it's actually the occupational hazard to fertility.
Correct.
Inhaling those solvents,
yes.
using toxic products, and those are sometimes so obvious, but something the patient can't really get away from. So I guess that's where integrative care comes in, and we help the patients to cleanse the liver for a couple of months or increase antioxidant intake to try to help with free radicals and to scavenge those, or some acupuncture for stress reduction.
Absolutely.
Because those things that they can't really change, we have to somehow find ways to mitigate.
Absolutely, 100%. And again, it's very important to listen to the patients. Is again, not necessarily patients when they come to the clinic, we have to start giving them medication or starting IVF, but to identify what are the things that we can change and improve. And sometimes just changing for 2-3 months in their certain lifestyle or certain habits or social habits, it improves their outcome. They get pregnant, and again, we love seeing patients that get pregnant naturally if we can. And that's where we have to just focus, and we ask the question, we have to spend time, and we have to know everybody's what they do, what is their routine, what's their lifestyle, what time they wake up, do they have to get to work early in the morning, what's the distance they have to drive. And those are not the questions just because we are curious, but it does affect as reproduction and basically their well-being in general.
Some of the things that I want to find out is how they're actually getting along in the relationship.
Yes.
Yeah. Because there can be some resentments or like an ongoing argument, or maybe he feels like a sperm donor who's forced to perform at a certain time. Yes. Things like that are subversive to the outcome strategy and way more subtle that they are definitely not going to bring into you.
Absolutely. Yes, absolutely.
Yeah. It's interesting, right? Remember our event that we did way back before the pandemic? We called it Fertility 101.
Yes.
And we were speaking to prospective patients. You were letting them know what's involved in an IVF workup.
Yes.
And I was letting them know foods and things they can do when they get to IVF or to help them optimize to do IVF.
Yes.
What would you like to say about that time when we did that together?
I think to raise the awareness is a main factor. Remember, anything in life, when we are planning to have certain things, let's say we want to have a career, we want to have a house, we want to have certain education, we plan ahead of the time. It doesn't happen that last moment. Let's say we want to buy a house, we plan maybe 10 years ahead of time, we get a financial advisor, we look at certain things. And I think it should be same for family planning. So if we raised the awareness, which I think that day we did, me and you together, we talked from different aspects of this field. It does help many individuals to plan and modify things ahead of the time if they don't have the resources or they are not ready to have a family yet. But that's their future plan. Now they can modify, they can change. If there is something in their lifestyle, they can modify that. They can know about their reproductive health. They can, for example, learn about how to document their menstrual cycles, so they have that self-awareness of, okay, my cycles are usually this many days, now it is longer or it's shorter, something is happening, now let's look to see what's going on and do different checkup. Nowadays I'm very proud to see more of the college age individuals, females or males, they come in and they want to check their fertility potentials. They are not ready to be parents yet, but they come in, they want to say, okay, this is my menstrual cycle pattern. Is that okay or not? Can you check my uterus to make sure there's nothing in there that I have to interfere or go through the start medication or surgical intervention? What's my ovarian reserve? Many guys, they come in and say, okay, what's my sperm? What's the motility of my sperm? If it is not okay, then what are the things that I can start to help it to improve?
Good for them.
Yeah.
That's so empowered, instead of the fear driving them that they're worried that they won't have enough or, that they don't have a good partnership, so they want to do an egg freezing, for them to have that information to present to a new partner or something, to know, just like they know their BMI or whatever metrics.
Knowledge is always power. And with that knowledge, occasions our patients, they come in very young age, they never even try to conceive, but they see, okay, I have lower ovarian reserve, so I want to do something about it before it's becoming more challenging. Or, okay, my sperm motility is low, now I can freeze this sperm, or I can save some. If this is progressive, I have something to work with for future.
We need to get that message out.
The information and basically the knowledge.
Yeah, it's true. I have a boy and a girl. My daughter is 16 and a half, and I have already seen her AMH is very low. We've done an ultrasound. Her egg activity is very low. And my son is 14, and he sits a lot gaming and doing different things. That is the normal behavior of this generation.
Of course,
and I don't think it's an accident that we have the technology that we do to keep the human species on the planet. But it is definitely a conversation that is new, because up to this point, it's been the health class and the sex education class about not getting pregnant. But I think that class has to be changed to include certain factors like you're describing. So
yes, learning about reproductive health is very important. And now what we see is also more modern families. We have single parents. There are females, they come in and for different reasons they don't have partners, or they had partners that they were not ready to have children. They come in and say, you know what, I want to be a single mom by choice, and how you can help me. There are resources to help them. Same thing for single father by choice, they come in. And I think it's always good to know what's your goal for future. Is also, we have patients that they feel like, okay, I might not ever want to use my eggs, but let me freeze it. But at least I don't lose that opportunity while I'm younger. And these are all, I think this is coming with current technology. When I was in college years, this was not for me. Nobody, gave me that information. I wish I had it and I could use it, but it was not there at that point.
Even in 2001, when I was 31, that's when I was told I wouldn't be able to have kids of my own. And that's when I started asking the questions and becoming empowered and figuring things out. And so I really respect that those people are coming to you and that you're able to welcome them in and normalize the conversation.
Absolutely.
For them to have a sense of, oh, wow, I didn't even realize, or to be validated, the sense of, I kind of thought there might be a problem, but now but now I have to address it somehow.
Absolutely.
And in the care of you and Dr. Vermesh, it probably feels very safe instead of frightening.
I think it should be, we have to make our patients comfortable. This is very private, it's very personal. They come in and sometimes we have, behind closed doors, we have the conversations that they never could have the same conversation with their parents, their sibling. And again, but we are there to help. And, everybody who they have the dream of parenthood at any point in their life, there are options available. Different ways to get there. But it's always good to, to start early, set the goals like everything else in life, and then work through to get to those goals.
Yeah. We're definitely talking about the way that humans are evolving.
Absolutely.
Without saying, hey, Tannaz, let's talk about how humans are evolving. It is really what's going on. And the more that we are able to talk about it, the more I think we might be able to put some of the brakes on these diminishing egg counts or these problems happening, or to bring awareness about the food that we have. The food that we have is a problem.
Absolutely, yes.
And it seems to be getting to become a bigger challenge for people to find food that's not processed or tainted with, or something that they prepare themselves. That's also part of the empowerment. And just to kind of fast forward a little bit, I think that the work that the patients put into improving their fertility and their health, their life, that will then be the starting point for the kids that come from the work with you, the changes to their food, the more empowered mindset that leads them to you in the first place to freeze some eggs. So when my patients come to me and they are feeling ashamed that they need to do this, I am really quick to remind them that if they need to do science, I want to remind them, well, you're doing this other work and it's from an empowered standpoint.
Absolutely.
To be the starting point for
and
those
remember,
kids.
Sometimes that's the only opportunity, the only time that we can modify their habits.
So, where they will be more compliant because they're doing fertility.
Absolutely.
Yeah.
You don't, I would say how many patients that I had that when they realize, okay, unhealthy weight, and we are talking about extremes of, lower BMI versus high BMI, unhealthy weight that can affect their fertility, they start working through the healthier weight, and they got pregnant. And that opportunity, they kept it because they realized, okay, this affected my reproductive health that, it took me a while to overcome, so let's keep it that way. And as physicians, and definitely Danica, I'm sure we're always trying to find the opportunities to modify things that can have permanent effect on our patient health and basically their life. And that's, again, that extreme of weight and how they eat, that can be the only chance that we have, and we have to use it.
Right.
Take that opportunity.
I could not agree more. Just teaching people how to live better, how to make decisions that are going to benefit them, and the consequences of what happens in Starbucks all over the city. I teach acupuncturists how to do fertility acupuncture, and one day in class, I said, we are evolving to become less fertile. And one of the older women who has 2 kids, she was like, I take issue with that statement. And I said, well, that's because you're in the student mindset here. Yes. You're in acupuncture school and you have 2 grown kids. You don't know what's really going on. How we have these coffee shops and sugar all over the place, and then all these countless fertility clinics popping up. Yeah. I'm sure there's a correlation. We've never had a time where we have so much sugar in the diet.
Yes.
And the liver has to process that burden, and then the ovaries are kind of downstream from that.
Yes, definitely the diet. And also keep in mind, in the past, let's say I have patients that come in, okay, my family never had fertility problems, but they forget that their mother had them when she was in their 20s,
19,
in her
yeah,
20s. Or the grandmother had the mother when early 20s. So now we are postponing for good reasons to get to the
Career.
parenthood. It can be career. Females are more involved in different part of life. They are involved in politics. They are going to schools. They work. So with all that, postponing by itself is really nothing genetic, but we are trying to become a parent later in life. And plus changes in the diet, changes in amounts of exercise the parents were doing. They used to walk everywhere and do their shopping and grocery and come back. Now we are sitting in the car and going everywhere by car. We don't walk that much.
Working
We don't
at
do that.
home, Zoom.
Yes, we're sitting on the computer. So all these changes that it can affect different part of our health, including our reproduction.
Yeah, it's important for the patients and the listeners to realize that by the time our fertility has been affected, like the reproductive system is not like the cardiovascular system. Reproductive system is the one that seemingly can be discarded if we are supposed to just keep ourselves alive. So all of the little stresses and things, like fertility to be an issue, is kind of a blessing inside of a curse, perceived curse, because it gets us to look into, oh, I didn't realize I have SIBO or endometriosis or some kind of blood clotting problem or a problem with methylating, right?
Right.
You know, the MTHFR gene mutations, something. So all of these things are being discovered because women and couples before now had trouble conceiving.
Yes.
So that's, I mean, that's the good and the bad of this situation.
I'm sure, yes.
I'm just curious off the side, do you do laparoscopies for endometriosis?
Not anymore.
Okay.
No, not anymore laparoscopy because first of all, timeline, and I do believe in terms, it has to be a team of surgeons to work for endometriosis patient, including colorectal, sometimes to call in oncology, to have urology. But we do have resources that if patients, they need to go through the laparoscopy, then we refer them to the group, the team of the surgeons to help them in a safe manner. Yeah.
And do they do endometriosis excision surgery?
Correct, yes.
So do you have some tip-offs in your patients with your background in endo, tip-offs that make you think, oh, this is probably an endometriosis case?
As you know, always endometriosis, it gets diagnosed very late, unfortunately. And patients, they come in with complaint of pain. And average in United States, it takes about 7 years from initial complaint to be diagnosed. Now we are becoming, as physicians in general, OBGYNs, we are becoming more proactive regarding endometriosis diagnosis, and the gold standard is laparoscopy. Now, when the patients, they come in to me and they have pain with menstrual cycles, or sometimes they have pain with defecations, urinations, and we cannot see any cysts in the ovaries, the concern might be the endometriosis. I refer them to do the diagnostic evaluation. Plus, now there are some biomarkers that we can send and see if there is a high level of those biomarkers. If there is, then that can be a first step to propose to go through the laparoscopic surgery.
Are you talking about like BCL6 and a uterine biopsy?
That's correct.
Yeah. Right. That's great that we have that now. And when those are elevated, to know that before putting in the one normal embryo that you have left.
Absolutely, yes.
You know, or to make the decision to maybe do another retrieval if you have the
absolutely
resources.
And one other thing that in our center we consider as a immunomodulator, because as part of endometriosis is changes in immune system, is offering patients to use intralipids at the time of transfer. And what it does, it decreases the natural killer cells in body of the uterus. So if part of this is related to the immune system that is overactive and prevent implantation by decreasing this cytotoxicity of natural killer cells, just temporarily, it works about 3 weeks every time we do the treatment. It helps with having better outcome and higher pregnancy rate.
By calming things down in the uterine environment, right?
Correct.
And you already have them using a little bit of aspirin in the protocol.
Absolutely, yes.
So, yes, I know Dr. Vermesh's episode, we talked about the trickiness to diagnosing the natural killer elevation.
Absolutely.
And so if the treatment is the same, then just do the treatment.
Yeah. That intralipid is from soybean, is soybean oil. So the only contraindication is patients they have allergy to soy, and that's it. It's very safe to administer. In the past, in other fields, we used to use intralipids as a parenthood nutrition. So patients that are malnourished, or they're malnourished, or they have failure to thrive because of different medical conditions, intralipid was offered as a way to help them to have nutrition if they cannot eat, and to help them. So now we use that in reproductive medicine as an immunomodulators for circumstances that patients that have recurrent pregnancy loss, or they have failed implantations. We transfer normal embryos to we don't get to the pregnancy, and we cannot find any other causes for failed implantation, and we see significant improvement in terms of outcome.
Yeah. I'm so grateful for those intralipids that are provided over there at the center. Let's talk about PCOS for a little bit, because we're talking so much about endometriosis, but PCO is another one of these inflammatory conditions that's out there now, probably in response to all of the sugar in the food. How do you go about working with women that have PCO?
We have a very good number of patients with PCOS. And if you imagine, it's on a spectrum of things that happens. Some patients, they have severe forms, and sometimes they are in the middle. How we diagnose it is the patients, they come in with irregular cycles, irregular periods, sometimes no period for a whole year. And it is also metabolic syndrome. So if you look at their biomarkers, they might be sometimes pre-diabetic. The testosterone, male hormone, can be high. And in occasions, they're normal range, but still patients not ovulating. And then we do ultrasound, we see the characteristic of polycystic ovary. Now, if the patient is having higher BMI, we try to work on their lifestyle, and they're basically improving to a healthier weight, healthier diet, and as you mentioned, to decrease the inflammation, and see if we can resume their regular menstrual cycle. If they do, then they're ovulating. They really wouldn't probably need anything else than that. So first, changing the lifestyle, and then in occasions there are patients that they have healthy BMI. They don't ovulate. They don't have a period. That's when we start working with medication, and again, holistic approach to decreases the inflammation and their stress level. And one other thing that we should always consider, PCOS patients, many of them, they also have other psychological challenges, such as depression or anxiety, that as physicians we should also address those those health issues, or basically help them to get through the challenges. It does help them to be consistent with the changes, with the medications and protocols.
Mm-hmm. Right. And looking at the thyroid, maybe.
But for PCOS patients, definitely before making the diagnosis, we have to rule out thyroid issues.
Mm-hmm. Yeah.
So we cannot make the diagnosis before checking to make sure that this is not other hormonal problems.
Mm-hmm.
Yes.
Right. Yeah. Polycystic ovaries. It's interesting because I have some patients, I think I mostly work with the diminished ovarian reserve cases, and they have friends who their friends stimulated 30 eggs, or they retrieved 30 eggs, and that makes my patients feel somehow inadequate. But a lot of the times those 30 eggs will not amount to many normal embryos.
Yes.
Because the way that the body is releasing all of those secondary follicles, but there's at the end of the day, there's usually one or two that are the ones in nature that are rallying to be the best, right? So
this is what I always tell the patients, we need one good egg and one good sperm to get to the baby. And it's not necessarily a game of the numbers. So not necessarily having more translates to having more blastocysts or normal embryo. And one thing that we have to always reconsider, having hyperstimulation or giving high dose of medication, getting a lot of eggs, actually it works reverse. And we have to modify, and I sometimes see patients as a second opinion, third opinion. They come in, they talk about previous IVF cycles that, okay, I got stimulated, I had this many eggs, and I had no embryo to transfer. And sure enough, when we go the lower dose and the lower number of days that they were exposed to those hormones, we get maybe lower number, but definitely better quality embryos. So yes, always we need only one good egg and one good sperm to get to a healthy baby.
Which is a very different messaging than has been the case for IVF for the past 2 decades that I've been in the field, where it was always like, it's a numbers game and we want to get as many as we can so that we can have them. But I think coming out of the quarantine, where the egg counts were dropped so drastically, that the RE started to say it's quality over quantity.
Absolutely.
And I think that has really helped with the psyche of these patients, because to be already stressed out about going to fertility, it can be expensive. It's so many appointments. It's all the things. But then to have the internal messaging of not enough. I'm not enough, I'm not making enough, or whatever. But for you to remind them to say it, it really is. If they can get one or two, and those have good quality because of the optimization, maybe the supplements, different food, things like the seed program, then there is a good chance of those to create some normal embryos.
Let me give you an example. What we noticed that even with the donor eggs, these are females that are healthy individuals, they are in their 20s, and if we stimulate that ovary or their ovaries with high dose of medication, and let's say I have seen patients that they had stimulation getting 50 eggs, which is, to me, that's not acceptable. So higher dose, longer, many more days of exposure, and then when we create the embryo, very, very poor results. And they are not patients. These are just donors. They're helping other individuals to get to the pregnancy. So that modification is a key factor to get to success. Again, not necessarily high dose and too many eggs.
Must be interesting as the physician prescribing the protocols when you switch gears from, okay, a diminished ovarian reserve to how I'm going to stimulate a donor. Right? It's 2 different parts of your brain.
Even for diminished ovarian reserve, Danica, sometimes we have patients that, they do better with natural cycle.
Yeah, even with the donors?
Yeah, not donor, not diminished ovarian reserve. Instead like, stimulating to get 2 or 3 eggs, doing no medication and just going for their own body, how their body is responding to their endogenous hormones, and just going for one follicle, getting one egg. Some of you have better results than having multiple eggs from even same patient.
Sure, because it mimics nature, right?
Yeah.
Yeah, that's so for you to say that should be speaking to listeners who have been so hung up on the thought of, I need to get more, I need more, I need to have an extra, like a surplus. Sometimes it really is painstaking or a lot of patience required to batch, maybe like get one and then wait and recover and then go back in for another.
Yes. It's a process.
It's a process. Yes. All of it is a process. I'm just curious. I want to talk a little bit more about the immune system with regards to things that haven't been looked at so much since COVID, but before we hit the COVID blip on the screen, there was a lot more consideration of like ANA, anti-nucleic antibodies, and APA, MTHFR. Do you guys typically screen for that, or is it just in women with recurrent loss?
So it really depends on the circumstances. So patients come in and with history of sudden changes in the symptoms. So we are worried about any type of rheumatologic disorder, as you mentioned, like lupus, rheumatoid arthritis. Then yes, we do. We check to see what's the level of inflammation, and in occasions we consult the rheumatologist, the person who can help them to help with the proper medications to decrease the symptoms and help to those antibodies to go down. Now, if patients come in and has a history of recurrent pregnancy loss, then we have to look to see what is the reason for that recurrent pregnancy loss. And as you mentioned, thyroid antibody can be one. This is something that can easily get missed. In multiple cases, patients, they check just the TSH, the thyroid, but not checking the thyroid antibody. So there are patients that they have normal TSH, but that antibody is very high, and that can be fixed by giving them treatment during the cycle. So bringing the antibody level down, it helps us to get to the pregnancy. Or patients that we have no explanation, they get pregnant and keep having miscarriages. And we look at for antiphospholipid antibody, if they have the antibody, just simply we have to just give them anticoagulation during the pregnancy. So it really depends on the context when they come in. And again, we have to be very careful in terms of what testing we are ordering. And consideration should be also for patients that not necessarily insurances covers fertility evaluation. So we have to be very careful in terms of what testing we are ordering.
Right.
Yeah.
Yeah. The responsibility of that landing on the patient prohibits you from doing $1 million workup, even though you want to rule a bunch of things out.
Our hands are really closed.
Yeah. As you were talking, I was thinking about progesterone as something that, the ERA, endometrial receptivity assay, the window of the best time to use the progesterone. What do you think about that? Do you use that test very often?
Not anymore. Why we don't use it that often anymore is I would say 6 years ago, it was a very routine practice to check to see what's the implantation, knowing 70% of the patients, they are receptive. There are only 25 to 30% that they might need less exposure or longer exposure to the progesterone. Then there was this data came last year looking at patients who went through this testing and seeing, okay, what's the outcome? Not necessarily it is helping most of the patients. So we stopped doing the error testing. Occasions we still offer the error testing, and those occasions are, let's say we check everything else and everything is fine and is unexplained failed implantation, then we offer the error testing and we discuss with the patient. It's very controversial these days, but nothing else left that we haven't checked, and we check. Yeah. Or again, endometriosis patients, there are good,
more
group
like
of
estrogen
patients,
dominant cases.
Absolutely, to offer, or again, extreme of weights. That
extreme
of weight.
Oh, tell me more.
Low BMI or high BMI, they might have changes in the window of implantation. In our experience, again, these are not published data, but those are circumstances we offer to the patients.
Right. Well, a lot of patients are doing like a Mira app, or they are checking their urine and they're able to see that their progesterone is low, or they have, I'm dating myself here, talking about the saddle pattern in a BBT, but there's a dip in the luteal phase of the progesterone, and those cases will consistently not become pregnant. And so then I say to them, please make sure to bring these diagrams and show your doctor so that he or she knows to augment progesterone in your luteal phase post-transfer, that it's been addressed somehow, because that's such an easy fix.
It's very easy fix, but the error testing, it requires an endometrial biopsy.
Right. It's just painful.
It's not comfortable. If we have to do it, we do it. But to offer to all of the patients or before the transfer, because at some point, some clinics, they would offer to all the patients before transfer.
Yeah, I would think that the less manipulation of the uterine lining, the better, especially now that we have these microclots and inflammation and all of the things.
Possibility of a scar tissue and damaging the lining. So we have to be very careful who we are offering.
It's such a balance act. Well, Dr. Tolou, you have given my patients so much value, so many things to consider, to think about, to remember. Is there anything that you would like to leave, to end the interview with, like a message of hope or something?
I really appreciate you, Danica, and to be here. And what I would like to tell all the patients who are going through this and young individuals are stay positive, take care of your mind and your body. Don't forget about the mind part, and also consider this as your goals. Don't give up on it. I have not seen anybody who wants to be parents that they don't get there. There might be different ways to get there, but they all get there.
Right. It's true. They reframe what parenting looks like for them.
Absolutely. Yes.
Right.
Thank you for having me today.
Sure. So listeners that want to meet you, how would they find you?
So I work at Center for Fertility and Gynecology. So they can search online, Center for Fertility and Gynecology. And then our phone number is 818-881-9800. That's our office number. And Paula, our manager, she's lovely. It would help them to schedule. Yes, we love her.
Yes. Well, I'll put Paula's email address and the website and the phone number in the link below the YouTube video. But Dr. Tolou, thank you very much for being with me today. And
it was a pleasure.
Giving so much good info.
Thank you, Danica, for having me.